All right, so we are covering mood disorders today. And mood disorders, we're going to be covering depression and mania specifically. And mild and temporary forms of these things are part of normal existence, right? So it's normal to feel sadness sometimes. It's normal to feel elated sometimes. But these can be taken to the extremes. And that's when it results in serious disruptions in life, possibly depression. Okay, so let's talk about depression. So a major depressive episode is required for the diagnosis of major depressive disorder. Okay, so you have to have one of these episodes to get the diagnosis for depression. Major depressive disorder is the technical clinical diagnosis. So during a major depressive episode, these symptoms have to last for at least 2 weeks. So you have depressed mood developing gradually over weeks or months. It usually lasts for several months and then ends gradually. There is a loss of pleasure or interest in the usual activities. This loss of pleasure is known as anhedonia. Many individuals in this situation look lifeless, boring, dull, rather than sad or crying. It also impairs concentration, negative view of the world that can really paralyze decision making. Individuals also show disturbances in sleep. They might show psychomotor retardation or agitation. So this can be seen in terms of this loss of energy, or they might constantly feel like they're kind of keyed up. That's agitation. Feelings of worthlessness and guilt, and then recurrent thoughts of death or suicide. Major depressive disorder then requires that you have these major depressive episodes with no intervening periods of mania, and we'll talk about what that means in just a second here. If left untreated, major depressive episodes typically last for about 4 months or more, and women are significantly more likely to develop depression than men are. With a manic episode, with mania, we're looking at the opposite end of the continuum. So with mania, we have this elevated, expansive, or irritable mood, inflated self-esteem, decreased need for sleep, extreme talkativeness. You have this flight of ideas where you're moving from one idea to the next, to the next, to the next. You might be, on the phone 24/7, accomplishing so much in your job. You have boundless energy. You only need to sleep 1 or 2 hours per night. You might have zero appetite. You're very distractible and hyperactive, and you might engage in reckless behavior. So sometimes this can be going on shopping sprees. This can be reckless sexual behavior. It can result in hospitalization for some individuals, or they might experience psychotic symptoms such as delusions, these false beliefs, or hallucinations, false sensory experiences. There is another less severe type of mood disorder falling more towards the manic end of the continuum. It's called hypomania. So it shows many of the same symptoms that mania does, except they are not as severe and the symptoms are not severe enough to require hospitalization. You also don't show the psychotic symptoms like delusions or hallucinations. Okay, so you might be very impulsive, you might have this flight of ideas, you might have this grandiose, expansive thinking, but again, the symptoms are not severe enough to result in hospitalization. If the individual has to be hospitalized for the manic symptoms, the diagnosis then is not hypomania, it will automatically change to mania. Some individuals might experience a mixed episode, a mixed mood episode in which they meet criteria for both a manic episode and a depressive episode in 1 week. Okay, so this is a very rapid shift from one end of the mood continuum, from manic to depressive, in a very short period of time. With mood disorder syndromes, the technical diagnosis for individuals who shift back and forth between mania and depression, this is called bipolar disorder. And bipolar disorder, you can have either bipolar 1 or bipolar 2. So let's start with bipolar 1. So individuals who have bipolar 1 experience full-blown mania. Okay, so they meet the criteria for full mania or for a mixed episode, and that they also experience the full criteria for major depression. Okay, so they vacillate, they move back and forth between mania and depression. This used to be called manic depressive disorder. We've since changed it to bipolar disorder. Individuals who experience bipolar 1 disorder have a very high risk for suicide. About 10 to 15% actually complete suicide. The average age of onset is around 20. And for most individuals who experience this, more than 90% who have one manic episode will have another in the future. So it's a recurrent disorder. Additionally, there is a specifier that goes along with bipolar disorder that's called rapid cycling. So individuals who experience rapid cycling have 4 or more episodes of either manic or depressive or mixed in 1 year. And these episodes are separated by either full remission, so let's say they're experiencing a manic episode and they return to a normal mood, so that's full remission, or they might switch from a manic episode to a depressive episode. So switching to the opposite end of the pole, the opposite end of this mood continuum. So then bipolar 1, you meet full criteria for a manic episode or mixed episode and for a depressive episode. With bipolar 2, the individual meets criteria for major depression, but they do not meet full criteria for mania. They meet criteria for hypomania. If at any point a manic episode, full criteria for a manic episode becomes present, the diagnosis shifts to bipolar 1. Okay, so bipolar 2, hypomania. Bipolar 1, we have full mania. For many individuals who have bipolar 2, they will eventually go on to develop bipolar 1, developing these manic episodes. And additionally, there is a high suicide risk that is associated with bipolar 2 as well. It can be very challenging as a clinician to be able to distinguish if an individual is experiencing unipolar depression, so this is just major depression, or if the individual is experiencing bipolar depression. So let's say someone comes in to speak with you and this person is in the throes of depression, and you want to determine, is this person just experiencing unipolar depression or are they experiencing bipolar depression? There are some ways to distinguish that when you start to do the assessment process and learn about their symptoms. So if individuals are experiencing unipolar depression, they're more likely to experiencing psychomotor agitation or retardation, more likely to experience anxiety, insomnia, so this is that lack of sleep. They may be overweight or underweight. Oftentimes they describe their symptoms as worse in the morning and they get better as the day goes on, and they are less likely to report psychotic symptoms like delusions or hallucinations. If the individual is experiencing bipolar disorder, they're more likely to show psychomotor retardation as part of their depression, more likely to show lethargy, so this is, extreme, not really wanting to do anything, more likely to be sleeping all of the time, hypersomnia, more likely to be overweight, showing hyperphagia or excessive hunger. Oftentimes their symptoms are worse in the evening, better in the morning, and psychosis, so those delusions and hallucinations, are more likely when individuals are experiencing bipolar disorder. Similarly, there are some longitudinal features. So this is how the mood disorder plays out over time, over the long run, the longitudinal features that can distinguish unipolar depression from bipolar disorder. So for individuals who are more likely to be experiencing bipolar disorder, usually they have a family history. Individuals with unipolar depression, less likely to have a family history of mood disorders. Individuals experiencing bipolar disorders, so premorbid functioning. That means before the full-blown disorder had taken hold, they were more likely to be outgoing, active, and uninhibited. Individuals with unipolar depression, premorbidly more likely to be shy and insecure. Unipolar depression, no prior mania or hypomania. With bipolar individuals, it's important to assess, have they experienced a manic or hypomanic episode in the past, and have they been hospitalized for their mood disorder in the past. With unipolar depression, it's less likely that these individuals have been hospitalized for their particular disorder. There are other types of mood disorders, so we can talk about dysthymia or chronic depression. Chronic depression is basically a low-grade depression. So these individuals experience depressed mood, they experience this anhedonia or lack of interest in things that they used to find enjoyable, but the symptoms are not severe enough to qualify for a diagnosis of major depression. Usually these individuals experience these symptoms for at least 2 years, oftentimes longer. Typically they function adequately, but they have these vague feelings of sadness and of emptiness. Oftentimes these individuals have shown these symptoms from early in life, so childhood, adolescence, and it's a chronic course. It follows them throughout their lives. They may experience a break in symptoms, but typically this break in their low-grade depression does not last for longer than a couple of weeks. Additionally, we have a diagnosis called cyclothymia. And with cyclothymia, the individual experiences kind of like a hypomania and kind of depression, these vacillating back and forth between hypomania and depression, but it's not severe enough to qualify for a diagnosis of bipolar 2. These symptoms are typically present for at least 2 years, and sometimes there is a break in symptoms, but it doesn't last for more than 3 months at a time. Oftentimes, individuals who experience cyclothymia have a higher risk, 15 to 50% will actually go on to develop full bipolar 1 or bipolar 2 disorder.